Put the screen full screen. Yeah,
It's completely in full screen, sir. No problem.
yeah. Now I don't have to press any share screen. You will
Nothing,
only
nothing.
right.
Yeah. So, with all your due permission, we are live. A very good evening to everyone. This is Batul, the moderator for today's session from IJCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned nephrologist who is present here with us today. Indeed, it's my great pleasure and honor to introduce him. He is none other than the very renowned Professor Dr. Lieutenant General Prem Prakash Verma, sir. Sir is MBBS, MD, DM, NMMS, FICP, FACP, FRCP, FISN, FASN, FAMS, Principal Director at the Department of Nephrology and Kidney Transplant at Venkateshwar Hospital, New Delhi. With such wonderful insights and with his enriching experience, we are going to talk about the topic for today, which is when to start dialysis in CKD and AKD patients. So, now without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you. Please proceed.
Thank you very much, Betul, for the kind introduction. I think we can go ahead. Uh, Before I start, I think let's start from basics so that we are all together. God has given us two kidneys. Each kidney weighs around 135 grams. Now, 1 in 200 to 1 in 500 people are born with single kidney. And keep in mind, life is fully compatible with a single kidney. We all know that each kidney has got around 1 million nephrons, which is the unit of kidney. That means two kidneys together have got over 2 million nephrons, and they perform the basic function of filtration. And each minute, we know that there is 120 ml of filtrate is there. So what we call as glomerular filtration rate. That means in 24 hours, that is 1440 minutes, our kidney produce approximately 170 to 180 liters of urine, and 99% of this gets reabsorbed. So we are passing generally 1.5 liter of urine per day. Uh, Coming next, that we all know the basic functions of kidney, that is excretion of waste product, acid base balance, electrolyte and water, and concentration dilution of urine, erythropoietin, and vitamin D. They are the hormonal functions. Well, what is kidney failure? Kidney failure is of two types. One is acute kidney failure, which develops over hours to days, and mostly it is reversible. The chronic kidney failure, there is a progressive, irreversible loss of kidney function over months to years. So we have to have a minimum of 3 months of a bad kidney functions to call that a person is having chronic kidney disease. Let's first come to acute kidney failure. First 15 minutes, I think we should discuss about acute kidney failure, which is a very common problem. Uh, as a matter of fact, there is a rifle criteria which was devised in 2004, which divides the kidney failure. The rifle meant risk. I is injury, F is failure, L is loss of kidney function, E is end stage kidney failure. The risk meant that if the creatinine becomes 1.5 times the normal, or the GFR drops by 25%, this is called stage 1, or the person is at risk. When we say injury, the creatinine goes over 2 times, or the GFR drop is over 50%, and failure we call creatinine goes 3 times or more, or the GFR drops 75% or more. Well, this is only one criteria that you base on creatinine. Second, you have based on GFR that the GFR dropped by 25%, 50%, 75% to call it risk, injury, or failure. No. But one important factor is when you are practicing in your ICU, when will you call a person is having kidney failure if you don't have creatinine at that time? Keep in mind that if a person is having less than zero point 0.5 ml urine per kg per hour, that is for 6 hours. We know that we all produce 1 ml of urine per kg per hour. That means a 60 kg man is producing 60 ml of urine per hour. So if he is producing less than zero point 0.5, less than 30 ml, he is passing per hour, and you find for 6 hours he is not passing, he is passing less than that, that is, he is at risk of kidney failure or the first stage of kidney failure. Injury, we call it that if he is passing the same less than 30 ml per hour for 12 hours, so it becomes he has got kidney injury. And failure, if it is less than zero point 0.3 ml per hour for 24 hours or he is not passing urine at all, then for 12 hours, then we say he has got the failure. Well, this is one criteria. Second criteria, which came up in 2007, that is based on creatinine. And that is simply we say that if a person has got rise of creatinine by more than zero point 0.3 milligram, that's all. Or we say creatinine rise more than 1.5 to 2 times normal. That is called stage 1 kidney failure. If you find the creatinine has gone more than 2 to 3 times from baseline, it is kidney akin stage 2. And if the creatinine has gone more than 3 times the baseline or more, it is stage 3. Urine output criteria remains the same. For 6 hours, less urine. For 12 hours, less urine, or anuria for 12 hours. That's important what you have to know, that urine output is also a very important criteria. KDGO then merged both these criteria, and this is what is being followed today. If you find a patient in ICU, there is an increase in creatinine either by zero point 0.3 milligram within last 48 hours, he has got acute kidney injury. Or if that is not the criteria, an increase in serum creatinine by more than 1.5 times the baseline occurring in the past 7 days, it is called he has got acute kidney injury. Or if the urine volume becomes less than zero point 0.5 ml per kg per hour for 6 hours, as we have said. So these criteria, three criteria, will define that person has got acute kidney injury. The staging you do, that if it is 1.5 times to 2 times rise in creatinine, stage 1, 2 to 3 times rise in creatinine, stage 2, and more than 3 times the baseline, it is stage 3. So we have followed so far that what is acute kidney injury? Rise in creatinine by more than zero point 0.3 milligram only in last 48 hours, that you call a person has got acute kidney injury. Because what you see, the survival of patients 1 to 3 stage keeps going down as the Aiken criteria goes from 1 to 3. Well, just to introduce again acute kidney injury, that 7 to 18% of hospitalized patients will develop acute kidney injury. That means if your hospital, let's say, is 500 bedded, at least 25 patients hospitalized will have acute kidney injury. At least 5 to, they say 7 to 18, I'm saying minimum 5% will have acute, the hospitalized patient will develop acute kidney injury. Over 50% of patients admitted in ICU have acute kidney injury. Those requiring renal replacement therapy have over 50% mortality. That also you must know. That's very important. Among survivors, who 12.5% become dialysis dependent. I'll come next to this so that it becomes clear how bad it is. And keep in mind, this is the US data now that every year the incidence of acute kidney injury is increasing. Let's not go to age wise. This is a ICU study. What you find that out of 1032 of these ICU patients, 57% in developed AKI. Increasing AKI severity is associated with increased hospital mortality. So that ratio, stage 1, 1.6 hazard ratio, stage 2, 2.9, stage 3, 6.8. So that is very important that patients, the more severe the kidney injury, more the mortality in them. Let's come to this is a large study. What it is only showing that there's a 41% higher risk of death in AKI patients, even if they are not requiring dialysis. And if you go by stage, 36%, 46%, 59%, this is a large data of over 8 lakh 64 hospitalized patients. We have clubbed the data of many patients. That is the figure that you need to know. This is a long term outcome. If a person has developed acute kidney injury, what is the long term outcome? What will happen? These are large number of studies, 82 studies. What only it is showing that a large number of them will develop CKD also. End stage kidney failure, again, the risk is 5 times. So individuals with AKI are at increased risk of new or progressive CKD development or end stage kidney disease and death. So acute kidney injury is a bad disease to have. If you look at 5-year outcome of severe AKI who have required renal replacement therapy in ICU, at 5 year only 25% of the cohort was alive, and those survivors were only those with young and which had no comorbidity. So that means that every year, if you find people keep dying, so 25% only are alive after 5 years. Well, now let's come to when should I start dialysis in ICU or wherever in hospital? Should I start early or I wait? When what are the absolute indications for dialysis? You all know. If a person has got fluid overload or pulmonary edema, he requires dialysis. There is hyperkalemia, one requires dialysis. Severe metabolic acidosis, pH less than 7.2 or 7.1, one requires dialysis. Pericarditis, or a person is developing encephalopathy, they require dialysis. These are absolute indications. You can't get away. So whether a person is in stage 2 or 3, if he has got any of these, you have to give dialysis. There's no doubt about it. But if these are not there, should I give dialysis or not? Well, let's come to next. There have been couple of trials on this right from 2002 till date. We will come to them one by one to give you an idea what is this. This was a alien trial. Here, they wanted that early dialysis is better or late dialysis is better. So patients who were admitted in ICU, whether class 2 or 3, if the NGAL was more than 150, majority was surgery patients. And what they found in them that RRT initiation they did, and they found that possibly if they started dialysis early, the survival was better. Keep in mind, mark my words, if you start dialysis early, the survival they found was better. So they recommended that maybe early dialysis is better. Know it, this is a single center prospective study. not multi-center. So this limitation one has to note. Then came AKIKI trial, which is better time for initiation of dialysis. This is a multi-center study, 620 patients, AKI stage 3, ischemic or toxic, in patient were on catecholamine. So either they said, let's start early. Early means once you come to ICU, you find that the person is in stage 2 or 3. All right, they said, let's start them on dialysis. They found what is the mortality. And the other group was started late on dialysis. And the study found that there is no difference in mortality. There is, you are starting dialysis early, 98% are receiving dialysis in this group. Here, only 51% require dialysis. That means other people improved on its own without dialysis. So, had I given dialysis here, possibly they also would have unnecessarily got dialysis. So, RRT free days and all that. So, the conclusion was there is no benefit of giving early dialysis. Let's come to the next trial. This is an ideal ICU trial. Again, does early renal replacement therapy reduces mortality? Multicentric trial, 29 ICUs in France, 488 patients with severe AKI and septic shock, stage 3. Early initiation, they started within 12 hours of severe AKI. Once they saw, they started dialysis. Late, delayed RRT, they only started when they developed some problem which I mentioned, fluid overload or acidosis or hyperkalemia, encephalopathy, etc. And they found that 90-day mortality is similar whether you started early or late. So need for dialysis, if you started early, 97% you gave dialysis. But if you started late, only 62% got dialysis. Other people recovered automatically. So conclusion, don't jump and let the patient earn dialysis. Wait. Let's come to the next trial. This is the largest trial, START trial. Does early initiation of kidney replacement therapy decreases mortality? Again, a multi-center trial, largest trial till date, where you find there were 3,000 patients, and what they did, almost 1,500 patients in standard strategy, and 1,500 similar number of patients in accelerated strategy, early start. Again, you find a similar thing. There is no benefit of starting early. There is no difference in relative risk. Rather, you find the adverse effect were more if you started early. Crux among critically ill patients with acute kidney injury and accelerated renal replacement therapy was not associated with lower risk. So don't start early. Except one trial from a single center, no study has supported that you should start dialysis early. Every study says start late. Many times, dialysis people will start saying, your colleague will say, भाई dialysis दे दो इसको तो ये तो बेचारा बहुत परेशान है बहुत creatinine बढ़ गया है इसका. Don't bother. If he's earning dialysis because of fluid overload, acidosis, hyperkalemia, if there's encephalopathy, pericarditis, please give it. But don't give it otherwise, that if his creatinine is high, we give it. These are all the trial. I will not go in there. I have already told you that. This is again the same, except Elaine trial, AKIK trial, ideal trial, START trial. No trial is supporting early start of dialysis. This is again a comparison of all the trials, which is only showing that the mortality in all, except one Elaine trial, I told you, mortality in both the groups, early and late, in all trials is similar. Patients with delayed this all patients who did not receive KRT, this percentage, and dialysis dependence was no difference whether you started early or late. This is one more very interesting AKIK2 trial which came again from France. They said, how late is late? How long I should wait? So here they kept on waiting when even the patient was oliguria for over 72 hours, one over 112. These were the criteria. For 3 days, patient was oliguric, one was more than 112. So they one group they delayed even more, other group they gave it, and here they find that there is no point delaying beyond that. So you should not become one of those ki dialysis dena hi nahi till the last stage. That once this stage comes, you have to give dialysis. So that there is still a gray area. You cannot define that a person at this stage, I have to give dialysis, that I don't have to give dialysis. Keep in mind, don't be very early in giving dialysis. So I conclude in AKI that severe AKI requiring dialysis is associated with 50% mortality. Early dialysis is not associated with any mortality benefit or freedom for dialysis. So go slow. Don't jump for early dialysis. But however, don't delay too much. So if you really ask, we do not have still a very, very definite answer when to start, individualize the patient. And once a person is in stage 3, person is developing one of the complication, start dialysis. Let's come now to chronic kidney failure. Everybody may be keen to know that. We know that stage 1 CKD, if the GFR is between 90 and 120, stage 2 is 60 to 90, stage 3 is 30 to 60, stage 4 15 to 45 30, and stage 5 less than 15. Now, this is a KDGO classification of CKD that we are considering albuminuria also, A1, A2, A3, plus of course what is the GFR. We all know dialysis is required when the kidney failure is in stage 5 or GFR of less than 15. But should I give dialysis to everyone who has got GFR less than 15? If I start doing that, oh, it will I think world will be full of patients who are on dialysis. So who should be given dialysis? Though he has reached stage 5, which patient should be given dialysis? We know the symptoms, what they are. Patient may present with vomiting, fatigue, sleep problem, nausea, loss of appetite, weakness. These features, mind you, they are hints for chronic kidney disease patients. Keep in mind, awareness about CKD is very dismal. Now, let's come to patient has come to you, GFR is less than 15. So, emergency dialysis, we know we have discussed if there is uremic encephalopathy, pericarditis, or uremic pleuritis, other causes are excluded, person deserves dialysis. Refractory hyperkalemia or acidosis or hyperphosphatemia, which is incorrectable by medicines, you have tried, person has to be started on dialysis. Nutritional deficiency, where despite corrective measure, patient is losing weight, he is not eating, he is losing weight and getting sarcopenic, start dialysis. There can be also cognitive dysfunction. A person is becoming cognitively, he's not remembering things, cognitively, intelligence wise, he's going down. So, that also, if you think it is due to uremia, one can give a 4-week trial of dialysis, may help. And in children, the growth retardation, if it is occurring despite growth hormone and all the other medicine, these are emergent indications. So, when the GFR is less than 15, you have to start dialysis, provided these conditions are there. Now, let's say that none of these conditions are there. What do I do? Now, let's say GFR is further drawn. It is between 5 to 10 ml. Again, only if symptomatic or severe nutritional deficiency, then you give start dialysis. Less than 5 ml per minute. Generally, dialysis needs to be started as metabolic disturbances develop, which become unmanageable by drugs. Most of the patients with comorbidity get initiated on dialysis when GFR is less than 5. However, there are some young patients without comorbidities who tolerate uremia very well. I'm telling you, I'm of course a retired army officer. So one of my patients from Northeast came. They were looking pink still, cheeks were still pink. So he came to hospital. He said, "मैं वहाँ से आया, of course, now of course I've transplanted him. But we got his creatinine done. It was 31. So our lab felt, no, no, this creatinine is wrong. There is something wrong. Repeat karao, doctor sahab. You repeated it, it was 30.5. And this patient is totally asymptomatic. And he says, I am all right. I have got no problem. So, such patients who are asymptomatic, they don't have to be started immediately on dialysis. I have got a army officer's wife. Her creatinine is 15, 16, and she's absolutely asymptomatic. She said, my appetite is normal. I am passing normal urine. I have got no edema, nothing. So, you don't have to start seeing this is the GFR, necessarily start dialysis. Person should earn dialysis. Let's go next. This is the only trial which I am available. This is an ideal study initiating dialysis early or late. This is a trial from Australia and New Zealand. There were 828 patients. So, in one group, they started dialysis when the GFR was between 10 to 15 ml, and in group 2, when the GFR between 5 to 7 ml. They use cockroach god formula for GFR. So early group had 404, late group had 424 patients. They followed up these patients for 3.6 years. Primary endpoint was all cause mortality, and secondary endpoint was cardiovascular events or infection. What do you find? So this is same. What do you say? The initial early dialysis got started at 1.8 months after the patient was randomized. Late got started 6 months later. Now, what is happening? Uh, if you see here, the primary outcome death, this is the early start group, this is the late start group, you find the death rate is similar, P is equal to 0.75, whether you started early or late. The composite secondary endpoint, whether it's a cardiovascular events, whether it's a complications of dialysis, again was similar. If you see, P is all insignificant in all the columns. So what they only say, even if you look at the early start and late start, the mortality is similar. This is again the same thing. Mortality, early start group, late start group, time to death is similar. So this is 404 patient early and 425. That means there is no mortality benefit if you start dialysis early. This is the same ideal study data which is coming from New Zealand, Australia, that this was the study period red, where they found that early start had no benefit. In the next 8, 10 years, they find that people are not doing an early start, people are waiting to start dialysis. The conclusion is only that early start does not have any benefit in terms of mortality or anything. Rather, early start, you are putting a catheter, you might produce infections in them. It may be bad in the patients. So now this is just to conclusion. Mind you, there have been many comments on that whatever study was done, there are some limitations which are there in all the studies. In Australian study also, that they are all white people, the same population may be different in different countries. That is all right. The observations are there. But many people have tried in US also similar things. And by and large, barring except few studies, most of the studies point out that the mortality is similar. This is the last slide. To conclusion, early start of AKI dialysis has no benefit in terms of 90-day mortality, dialysis dependence, or any adverse effect. Hence, dialysis needs to be started when mandatory. Like in CKD, early initiation has no mortality benefit. Dialysis needs to be initiated when patient deserves it or earns it. So if you find a patient who is not able to eat, low appetite, extreme weakness, nausea, or any emergency indication, encephalopathy, pericarditis, hyperkalemia, pulmonary edema, or acidosis, then only you start the dialysis. Otherwise, there is no benefit. I stop here. So today we have only discussed when we should start dialysis, and for both acute kidney injury and chronic kidney failure, the message is never be in a hurry to start dialysis. Start only if the patient deserves it. We know the criteria for deserving it. Do not just jump. क्रिएटिनिन बढ़ गई, इसकी क्रिएटिनिन ज्यादा है, लेट्स गो फॉर डायलिसिस. नो, every patient is different. There are patients of CKD who do not pass enough urine. They are edemators, they have got pedal edema, they have facial puffiness, they can develop pulmonary edema, they have got high blood pressure. They may be requiring dialysis early. There are cases of tubulointerstitial nephritis, CIN, CKD, I mean, reflux patient, UTI, stone patient, who have developed kidney failure. They are passing good urine. So there is no edema, there is no puffiness, and the blood pressure is not an issue. They can tolerate uremia. They possibly will deserve it late. Thank you very much. If there are any questions, I am available.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and for making our viewers understand about it. We have received few questions from the participants. So, with all
Can
your
we
due
remove the
permission,
slides?
yes. So, we have received few questions from the participants. With
Yeah,
all your due permission, I would like to put across those
please,
questions to
please.
you. So, the first question is related to patient preferences regarding dialysis and treatment option that is available for CKD patients.
No, the dialysis options are only two. The best option for any CKD patient or end stage patient is transplant, where it's in terms of quality of life, in terms of longevity, in terms of long term financial, everything wise, transplant remains the best option. And today, with the better surgical techniques, with better immunosuppression, the life of transplant has increased significantly. I know the patient whom I transplanted 31 years back in 1993, he also comes to meet me. There are n number of patients who I transplanted 20 years back. They are coming and they meet us in the OPD. But average life of transplant is around 12 to 15 years. One should keep in mind that it doesn't mean that you have transplanted today, lifelong, it is gone. The life of a transplant average may be 12, 30, living related, 12 to 15 years, and cadaveric is little lesser, 10, 12 years. That is the average life, one should know. If after graft fails, go for second transplant. I have got two patients who have got third transplant. So there's not a limit. So that is the best option. Other option is the peritoneal dialysis and hemodialysis. Both modalities are equally good, especially in the initial 2 to 5 years. Both modalities are good and equal. PD, I mean, if it's a school going boy or is an office going person who cannot take leave every day, PD is a wonderful modality. Keep in mind there are countries like Thailand, Mexico, Hong Kong, they have got PD first policy that government only sponsors PD to them. It is only if the PD is not tolerable or anything happens, they come to HD. But after few years, the peritoneal membrane deteriorates and then HD becomes superior modality. But initial 2 to 5 years, both modalities are equally good. So one can choose a modality, the requirement, how you want to do it. Some people are fussy. I can't do tummy dialysis myself. I need a help. but that is a different thing. Some people have got very poor hygiene in village. He doesn't have any place to store. That is a different thing. Otherwise, both modalities are good.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question that we have received, and the other question is related to significant comorbidities. So, are there any significant comorbidities that may affect treatment choices?
Yes, one can say that. See, if a person is diabetic, right, and age is also more, so they do better on hemodialysis than peritoneal dialysis. As I said, both are equally good. But if a group of patients who are having diabetes and who are elderly, for them, hemodialysis will be a better modality. If a person has been operated in tummy, logically he is not a candidate for peritoneal dialysis because there's no place for catheter. So if there are scars in the abdomen, he cannot. But about the hemodialysis, likewise, if a person has got bad heart failure, he has got comorbid conditions, he cannot tolerate hemodialysis, his BP goes down. He can, person is cirrhotic, that person has got huge ascites also. So they cannot tolerate the blood removal, their BP drops. In such situation, peritoneal dialysis is the better modality because there's a slow process, there's no BP drop. So that's a better modality in such. So it is a different phenomena. Every person is different. Broadly, I said both are equal, but as I said, in patient with heart failure, very poor ejection fraction, 20%, 25%. Person with liver failure, possibly PD is a better modality. And people who have got abdominal scars, abdominal surgeries, and for them, hemodialysis is a better modality.
Thank you
Yeah.
so much, sir. Thank you for answering that question. Moving ahead with the other question that we have received, and the question is related to electrolyte imbalances. So, are there any life threatening electrolyte imbalances that one can experience, maybe the AKD patients or CKD patients?
Yeah. As I mentioned to you, the commonest is hyperkalemia because one of the function of kidney is to throw the potassium out, and that is a dangerous thing. That whenever there is a life threatening hyperkalemia, we say normal is 3.5 to 5.5, or some labs take it 3.5 to 5.15. So whenever the up to little bit of potassium, we in CKD patient we still accept it because they tolerate it. Let's say up to 5.5, I keep little quiet, but once it goes above 5.5, especially 6, so that is a condition where you have to give dialysis. So that is an emergency dialysis you have to give to these patients. Sometimes you have got hypercalcemia. There are patients who have got increased calcium level. You try to control with the drugs, bisphosphonates or other zoledronic acid. Sometimes you are not able. At the severe hypercalcemia, yes, you have to give dialysis to remove calcium. That is also possible. Likewise, not very common, but sometimes you have got hyperphosphatemia also. So in such situation also, you dialysis will help. Keep in mind, many of the patients you should be aware, like in earthquakes, we had Latur earthquake, Latur in Maharashtra, or other places earthquake. There are cases of rhabdomyolysis. Because of earthquake, the muscle damage is occurring. Sometimes people do rigorous exercise, and if the muscle damage is there, it leaks potassium out. So therefore, there's a hyperkalemia. So that is a urgent indication. So hyperkalemia remains an urgent indication for dialysis. It's an emergency. So that electrolyte imbalance one should keep in mind. Others are not very common: hypercalcemia, hyperphosphatemia, requiring dialysis, but hyperkalemia, yes.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the last question before we conclude the session. And the question is related to patient's overall condition. Like, suppose, example, sepsis or trauma. How do these kind of problems influence the decision of a patient's overall recovery?
Very difficult question, but uh, you said uh, you said sepsis are trauma. What happens? Say again. Does it influence the? See, it should not influence, because that is the general concept. Many times people feel that the person has got sepsis, person has got more cytokines, more leukotrienes, more of these uh, cytokines are TNF, interleukin 2, are these are there. So can we remove it? We do early dialysis, can we remove it? Many people believe that. Many people believe in ICU setting, trauma setting, sepsis setting. Possibly we should go for early dialysis, but unfortunately the trials do not support it. Many time in ICU, I go, or any of you going, the other ICU staff or other patient will say, Baba, inko, he's in sepsis, he's in shock, or whatever. You do it. So possibly dialysis is not the ideal way in such setting also. We have got different modalities. We have got filters that can absorb cytokines if provided a person reaches the ICU in the initial phase, early phase, but that is in the early 24 hours is there, then these absorbent columns can absorb. That is a different scenario of dialysis. But so far, and also keep in mind that some people in sepsis and all, what is more important from your point of view, that when the patient's mean arterial pressure is pretty low, then dialysis may not be possible. So that is the time the other form of dialysis, what we call CRRT, continuous renal replacement therapy, which is a continuous process. Dialysis keeps running for days together. So there it is slow. Normally, if we take a blood for during dialysis 300 ml per minute, so there the blood flow rate is 150, half of that. So that's a slow process which does not cause stress or strain on the body or heart. So, in a condition of sepsis or bad settings, we can always go for CRRT. That is a different modality of dialysis or renal replacement therapy, which is very popular. Rather, in US, they don't believe in dialysis. In ICU, they only go for CRRT. Europe, it is different. They believe in dialysis also. But so every country has got a different, but in settings where the blood pressure is low, person is in shock, septic shock, the CRRT is a better modality of renal replacement therapy. But if the blood pressure is good, patient has got normal blood pressure, dialysis is an excellent modality.
Thank you so much, sir. Thank you for answering that question and all the other questions for our viewers and for making them understand about the topic in such a simple manner. The way you have simplified the whole topic for making our viewers understand about it in such a simple manner. Thank you so much, sir. Thank you for your valuable
Thank you
time and
very
for
much.
being
I
here.
think appreciate, and I love these. I love the sessions. It is always good to interact with friends. Thank you very much for giving the opportunity.
Thank you
Grateful.
so much, sir. Thank you for your
Bye bye.
valuable
Bye
time.
bye, and good night.
With this, we are concluding the session here for today. Until next time, thank you all.
Bye bye.